Boys, you have to be quiet because I have to go into work.
Hello and welcome to the Nurse Family Partnership Global Research webinar series. I am Susan Jack and I will serve as the moderator for today's event. I am the Global NFP Research and Evaluation Director and a professor at the School of Nursing at McMaster University. And McMaster University is located on the traditional territories of the Mississauga and Haudenosaunee Nations, with the lands protected by the Dish with One Spoon Wampum Agreement. Just at this moment, if I could ask everyone to mute their microphone, that would be greatly appreciated. So today, along with my NFP colleagues who have joined me today, we acknowledge the traditional custodians of every land we meet from virtually. We pay our respects to elders past, present, and emerging, and we celebrate the global diversity of all Indigenous, First Nations, and Aboriginals peoples, and their ongoing cultures and connection to the lands and waters upon which we all rely. May we seek new relationships with the original peoples of the lands in which we live and work, relationships that are deeply based in honor and with deep respect. May we be guided by right action as we seek to transform our personal and institutional relationships with Indigenous friends, colleagues, and neighbors. So in our time together today, our speakers will be sharing their reflections of the research conducted to develop the evidentiary underpinnings of the NFP program and to discuss recent innovations and actions that are poised to shape the future directions of NFP as it is evaluated and implemented in multiple countries around the world.
You're muted, Susan.
Oops. Just a reminder, if everyone can mute themselves. We're hearing many wonderful conversations as we all join on here together. So as I was saying, our speakers today are going to be sharing their reflections of the research and the work that's going to guide future directions of NFP as it's adapted, evaluated, and implemented across the globe. And we are scheduled here together to connect and share information and to have discussion for 90 minutes. And our presenters will be sharing their work and their reflections and insights for about 60 minutes. And then we'll transition for an opportunity for about 30 minutes for questions and discussion. So again, I'll have everyone please mute your microphone. And as our speakers are talking, if you have any questions, please add them to the chat function. And later on, I'll also ask if anyone would like to raise their hand if they have any questions. So it's really only fitting today that as we relaunch the NFP webinar series, that one of our first two speakers is Dr. David Olds, who is a professor at the University of Colorado and a primary investigator at the Prevention Research Center for Family and Child Health. And Dr. Olds truly grounded in his commitment to improve the lives of young children and families who experience social and economic disadvantage, created the NFP program, or in the NFP model of nurse home visiting, and really has dedicated most of his professional career, over 45 years, I believe, developing and testing NFP with different populations in the United States, and providing significant wisdom, insight, and consultation to research teams in at least 7 other countries who have been global contexts. And in recognition, really, of Dr. Olds' pioneering work in preventive sciences, in nursing, in maternal child health, he has received many awards and honors for this work, including the Stockholm Prize in Criminology, the Charles A. Dano Award for Pioneering Achievements in Health, and most recently, an honorary Doctor of Science from McMaster University. And in Nurse Family Partnership, there is a genuine acknowledgement and awareness that our work is strengthened through our collaborations and our partnerships. And so on that note, on the international team, our second speaker is Deirdre Webb, who joins us today from Belfast. And Deirdre is the inaugural Global Director for Nurse Family Partnership. She is a nurse, and in her past role as clinical lead, she led the implementation and provided oversight of the Family Nurse Partnership in Northern Ireland for over 13 years. In addition to being a remarkable colleague, a true mentor, Deirdre is also a powerful advocate for evidence-informed nursing and midwifery practice, and equally committed to ensuring that young families receive high-quality public health services in pregnancy and the postpartum period and beyond. In her new role, Deirdre is now responsible for developing strategic direction and expansion of NFP. So I welcome both of you, David and Deirdre, and I turn it over to you, David.
Thank you so much, Sue. This is a wonderful introduction, and I'm so happy to have a chance to talk with you all from around the world who might be interested in NFP. And so I'm going to start by simply outlining what Nurse Family Partnership is all about. It's a program of prenatal and early childhood home visiting by nurses on low-income mothers with no previous live births. And the program has found replicated benefits from a series of randomized clinical trials. And I think that one of the reasons the program has achieved this kind of replicated strong evidence is that we've tried to be clear about what exactly the program is trying to achieve and how it's going to achieve those goals with specific behavioral and contextual objectives and methods for nurses to use in guiding clients to improve their lives and the lives of their children. And I think it's fundamental that the program activates and supports parents' instincts to protect their offspring. We can elaborate on this more in a moment. But it's also very important to recognize that so much of this depends upon nurses having caring, respectful, strength-based ways of working with families. And the program has three specific goals. The first is to improve the outcomes of pregnancy by helping women improve their prenatal health behaviors. The second is to improve children's health and development by helping parents provide sensitive, responsive, growth-promoting care to babies and toddlers in the first 2 years of life. And the third is to improve mother's own health and her personal life course development by, in a way, relying on parents' drive to protect their child and recognizing that the protection of the child means also that one needs to protect oneself. And it's exactly that as the foundation, serves as a foundation for mothers improving their own health and the life course choices that they make, such as planning subsequent pregnancies, staying in school, making sense of the relationships they have with partners in their lives. And we can talk about this more in just a moment. The program has four fundamental foundations. The first is a foundation in attachment theory. This is a cross-species drive on the part of species to protect their offspring. We can dig into this more as well, but it's also important to understand the context in which families, children are functioning, and to recognize that human ecology, or today one might refer to these as the social determinants of health, have a bearing on parents' abilities to care well for themselves or their children. And the third is self-efficacy theory. It's one thing to know about these sources of influence on early health and development, But how do we go about helping parents improve those conditions? And that's why the program is built on self-efficacy theory, which is designed to help parents set small, achievable goals and objectives that will help them become more confident in transforming their protection of themselves and their children. And it's also grounded in developmental epidemiology. What do we know scientifically about those specific behaviors and contextual factors that either promote or inhibit healthy development, again, on the part of the mother and the child? This slide, I apologize for its complexity, but if you'll bear with me a little bit, these goals come together to help transform the health and development of vulnerable children and families over the life course. And here's an example. The program is designed to help women improve their health-related behaviors, especially cutting down on use of substances, for example, or avoid stress during pregnancy, to the extent that the program helps women cut down on the use of substances and avoid stress. It means that the baby is going to be developing during gestation in a healthier way, and in the newborn period is less likely to have irritable, fussy behaviors, dysregulated behaviors that make it harder for parents to regulate their own behavior in caring for the child. And so the emphasis on promoting competent caregiving is met with a newborn who is easier to care for. And the third major goal is to help improve parents' life course. And to the extent that the program improves parents' the planning of subsequent pregnancies, the quality of partner relationships, economic self-sufficiency, and avoidance of substance abuse on the part of the mothers postnatally, that means that it's going to be, those factors will have a bearing on the quality of care that parents are able to provide, but also will shape the context in which children development into adolescence, where those families are less likely to be embedded in social networks where children are going to be exposed to negative peer influences. All of this has an impact on the child's adolescent and adult functioning, as you will see here in a moment. And this entire enterprise is built on three fundamental principles. The first is to build a program that has exquisite clinical excellence. And the second is to embody this enterprise in scientific integrity. We need to know whether this program can really make a difference in preventing adverse conditions on the part of mothers and children. And that comes through replicated randomized clinical trials. And the third principle is mutual accountability. Accountability to the families we serve, accountability to the governments that are funding these programs, and accountability to one another, to have this clear commitment to doing the very best we can. And as Sue said earlier, it's partly because we are together in this. We in the US conducted 3 foundational trials beginning in 1977 in Elmira, New York, that have served as the initial foundation for this work. The original trial in Elmira, New York, tested the program with 400 families, primarily low-income white families living in a semi-rural area. You know, we found beneficial effects in that first trial, but we realized, I should say, that we needed to know whether this program might work with minorities living in a major urban area. So we replicated the trial in Memphis, Tennessee, here in the US, with a large sample of primarily low-income Black families. 1,138 registered during pregnancy, and 742 followed by design postnatally. Many people, when they reviewed the beneficial effects of the program early on, said, gee, you got a program that looks good, but you know something? You could do even better if you were to hire paraprofessionals to do this work. And so my attitude was, yeah, that may be right. So let's test it. So in our Denver, Colorado trial begun in 1994, we systematically randomized families to either a comparison group that received transportation and screening, or a group that received transportation screening and paraprofessional home visiting, or a group that received transportation screening for the child and nurse home visiting. And I'll share those results for you. By the way, in all of these trials, the comparison group families received more services than they normally would in the communities. That is, they received transportation, health and developmental screening for the child in the first 2 years of life. They all received more than they would normally. And that's a motivation to participate in these trials. The Elmira sample, 400 families, no previous live births, registered before the 25th week of gestation, 89% white. We allowed a small group of families to enroll, even though they didn't have the sociodemographic characteristics used for sample recruitment, which were being poor, being unmarried, or being teenaged. This 15% of this sample was not poor, and they were married, and they were not adolescents. But note that 48% of the sample in the Elmira trial smoked 5 or more cigarettes per day at registration. Okay. One of the findings that's been of real interest to people around the world has been the reduction in the rates of state-verified reports of child abuse and neglect in the first in the early years of life. One of the things we found was that there was a significant reduction in the rates of state-verified reports of child abuse and neglect for families who received prenatal and infant home visiting compared to the comparison group or control group. This yellow bar represents children or families where the nurses visited only during pregnancy and the immediate postpartum period. Okay, significant reductions through the first 15 years of the child's life. And let me just go back. That was not, thank you. And we also found at 15 years that among the mothers, there was a significant reduction in the rates of self-reported arrests among mothers who had 2 of the 3 risk characteristics used for sample recruitment. That is, they were unmarried and poor. And that we see the reduction in comparison to the control group and the nurse visited during pregnancy and infancy, a significant reduction. Not so for mothers who were married in higher SES. There's no effect in that higher functioning subgroup. And when we look at the youth's self-reported arrests through child age 19, we see a significant reduction in youth arrests through age 19. These effects were most pronounced, by the way, in the first 15 years of life. And that's the period where there is adolescent antisocial behavior, which has been associated with child abuse and neglect. Later, arrests and antisocial behavior are more normative. We also see that there was a significant increase in the interval between the birth of first and second children for that same low ELCS unmarried sample in the Memphis trial. Very close subsequent pregnancies in the control group, the group that received the nurses during pregnancy and infants pregnancy. There's a slight improvement, but the real difference is present for those families where the nurse visited during pregnancy and through child age 2. Our Memphis trial we spent a lot of time trying to make sure that we get the very right nurses to do this work. So we very carefully evaluated them from the standpoint of their empathy, their respect, their caring. And by the way, those same principles applied to the Elmira trial in hiring nurses. 1,138 families served during pregnancy, with 748 followed by design postnatally. All had no previous live births, 89% Black. These families were extraordinarily poor. 85% of them in about 1990, when they actually enrolled, were living below the federal poverty guidelines. In the US, that means that they really had to make a decision about whether this month I'm going to pay for my rent or food. Very, very poor. And they lived in neighborhoods that were nearly 2.5 standard deviations above the national neighborhood adversity standards in all of the United States. These are families living in abject poverty in unsafe neighborhoods. And what we found in the Memphis trial, first of all, the rates of state-verified reports of child abuse and neglect in the Memphis trial were only 3%. So it was that rate was far too low to detect the beneficial effects of the program on state-verified reports of child abuse and neglect. So we turned our attention to the number of days that children are hospitalized with injuries or ingestions in the first 2 years of life. And here we see that postnatally, there is a significant reduction in the number of days that children are hospitalized for injuries and ingestions. Moreover, that effect is most pronounced among those mothers who have few psychological resources to cope with adversity. This means that this scale is a combination of mother's intellectual functioning, sense of mastery or self-efficacy, and her mental health functioning. And we see that in the Memphis sample, the number of days that children are hospitalized with injuries shoots up in the control group, not so in the nurse-visited condition. We think this has to do with the nurses helping mothers become more successful in coping with adversity. We also see by age 18 that the offspring, the children born to mothers with low psychological resources, and by that I mean lower than the median value in psychological resources in the Memphis trial, they had significantly reduced rates of government documented disability compared to their counterparts in the control group. Those who had high psychological resources in that sample had low rates of disability overall, and there were no treatment control differences. And we see for the sample as a whole, there is a significant increase in the rates of graduation with honors on the part of the nurse-visited sample. This is children, irrespective of mother's psychological resources. They are getting on, graduating with honors and making additional advances in their lives. And in our Denver trial, we see that we again focused on hiring the very best nurses who have those strong interpersonal skills to be respectful and empathic and caring with the families they serve. Registered 735 pregnant women, no previous live births, 45% Latina. We wanted to test the program in a context where there would be a large portion of Latina mothers because they compose a very large subgroup of minorities in the US. 16% Black. All of the families were living below what was then the federal poverty guidelines, which was below 133% of the federal poverty guidelines, or they had no private health insurance. And 23% of those who registered during pregnancy reported smoking at registration. This slide shows the overall pattern of results that we see summering across all of the outcomes in the Denver trial. We see that nurses produced effects that were significantly better than their comparison group counterparts, while those visited by paraprofessionals fell in between. And I'd like to just dig into this a little bit more with you. This slide shows, for example, that over the course of pregnancy, nurse-visited women had significant reductions in their urine cotinine values. Urine cotinine is the major nicotine metabolite. We measured it at registration and at the 36th week of pregnancy, and we see significant reductions. Not so falling in between the group of mothers visited by paraprofessionals. And when we look at the impact of the program on children's language functioning, we see that by age 4, the nurse-visited group has superior language functioning overall compared to the counterparts in the low psychological resource group, with the paraprofessional falling in between. I don't want to bore you with too much detail on this, but in the Denver trial, the low psychological resource group comprised 40%, not 50, but 40% of the overall sample, because we used the raw score values from the Memphis trial to determine what the low psychological resource group in the Denver trial would consist of. But look at what's happening for the sample as a whole. No differences. So it's a benefit when we look at child outcomes that's concentrated in those who are born to mothers who have the fewest resources, psychological resources, to cope with adversity. And we look at the timing to the first pregnancy. We see here a survival curve that shows the control group, the paraprofessional visited group, and the nurse visited group. And what we see is that, again, there are longer intervals between the control group and the nurse visited group, with the paraprofessional group falling right in between in terms of the interval between the birth of first and subsequent children. And if I can, for just a moment, the timing of subsequent pregnancies is incredibly important, because it allows mothers to focus their limited resources on the care of that first child. And it also has a bearing on the mother's abilities to organize her life and make plans and execute those plans with regards to staying in school and finding work. All of that depends upon planning the timing of subsequent pregnancies. And also what we see is that there is we've thought quite deeply about what it will take to move an evidence-based program from the research lab into community practice. And so here are some of the key lessons that we've learned and we think are critical as we replicate the program here in the US and around the world. I'd just like to take a couple of minutes and share these insights with you. It's critical that we get that we focus this program on mothers and families in need. given the results that I just described to you, you can see that the benefits are most pronounced where the need is greatest and there's greater room for improvement. It's also critical that we hire the right nurse. Again, I know I'm sounding like a broken record here, but just bear with me. We have to hire nurses who are sensitive, empathic, caring, respectful, because it's those people who can overcome the natural apprehensions that vulnerable mothers and families have about letting someone come into my home or participating in research, any of those things that people are naturally apprehensive about. So it depends fundamentally on communicating caring and respect from day one. What I haven't emphasized enough in what I just outlined was that in every single one of the trials that we conducted, we spent a lot of time up front making sure that the organization delivering the program was highly attuned and bought into these basic, the clinical model of the program, and that the broader community was prepared to orchestrate the nurses' efforts to make sure that those families in need could receive other services in the community. In our first Elmira program, um, the two pediatric groups in the healthcare providers in the community were parts of our local advisory committee. The head of the local health department was part of our advisory committee. We had representatives from the Department of Social Services and other nonprofits in the community, all of whom came together to support the program. The local organization that provided senior care for the elderly was engaged in the program, and these seniors, mostly women, would knit booties and blankets for mothers in the program. That level of community organization and commitment is critical. And I might add that you see that today, as I'll mention in a moment, especially in Scotland. You see that level of deep community ownership, which I think is so critical to the success of the program. There is a big focus, of course, on the clinical implementation of the program. The program is really designed with deep educational procedures and consultation procedures. There are program guidelines that are made up of detailed visit by visit guidelines that are adapted to the needs of each individual mother and her family and her child. So these materials are adjusted in terms of the timing and the content of the program content. The program currently has over 500 specific guidelines, what we call facilitators, that are used to guide mothers and families in addressing issues that they are most concerned about. There is a web-based information system that we have required organizations to buy into, because we need the information system to have some assurance that the program is being delivered with integrity and with alignment to the program model. And that information, in case you might guess, things don't always work out the way you would like. And so we need that information to identify areas that require continuous quality improvement. Assessing program performance and guiding continuous quality improvement activities is foundational in this process of replicating the program in community settings. Here in the US, the program is now serving over 385,000 families, has served, I should say, 385,000 families since we began national replication in 1996. and nearly 55,000 families are served annually in the program. It's operating in 40 states that you see colored in yellow here. There are nearly 2,300 nurse home visitors and nurse supervisors in the program nationally currently, and there are 733 counties in the U.S. where program is serving families. And worldwide, the program is operating in these countries, in these settings. I'll just go across the map left to right. It's working in British Columbia. It's serving families in Ontario, Canada. It's serving families now in Nova Scotia, Canada. The program is operating in Scotland, Northern Ireland, England, Norway, Bulgaria, and Australia, where the program is serving Torres Strait Islander and Aboriginal families. So we are deeply, deeply moved by the kind of collaboration that exists globally. And and in all of this, I suppose I just want to emphasize that we also want to continue the emphasis on high quality clinical implementation in science. So in the international replication process, we don't really know. We've made no presumptions about whether this program is going to work in contexts outside of the US. So we believe, first of all, that the program needs to be adapted and its testing of feasibility needs to be established in these new settings. We want to do a pretest and small-scale evaluation of the program in those new settings, and if possible, to do a larger randomized clinical trial of the program in these new settings. And again, there needs to be commitment to faithfully replicating the program in these new settings. And currently, as I just mentioned, we're working in these contexts, these other countries around the world. The program was delivered in Holland and in the Netherlands, and they conducted a well-designed and conducted randomized clinical trial. They served very high-risk, high-need families, and they found a reduction in prenatal smoking, an increase in breastfeeding, a reduction in intimate partner violence, improvements in the growth-promoting nature of the home environment, and reductions in children's behavioral problems, and reductions in state-verified reports of child abuse and neglect. In England, the program was conducted in a randomized clinical trial, but it was disappointing in some ways. There were no effects on prenatal cigarette smoking, birth weight, emergency department encounters, hospitalizations, or timing of subsequent pregnancies. But they did find significant improvements in children's school readiness and reading at ages 5 and 7, and that was preceded by an increase in maternal report of child language development earlier in life. This study was excellent, was executed beautifully, but there were challenges with its design and that it was open label, which meant that control group families, existing health midwives and health visitors were informed specifically which particular families within their communities were in the comparison group. And so there's evidence that the families in the control group received more visits from health visitors, many more visits than they would have normally before the conduct of this trial. And so more needs to be done to really understand the context of what it means to be in the control group in the English trial. British Columbia has conducted a trial of the program, and They found a significant reduction in the number of cigarettes smoked over the course of pregnancy, cannabis use over the course of pregnancy, and increases in children's language, language scores, reductions in children's behavioral problems, and critically, reductions in the number of days that children are hospitalized with injuries in the 2 years of the child's life. And we've recently seen the preliminary results, prenatal results from a large trial conducted here in the United States, conducted after welfare reform went into effect and Medicaid eligibility levels in income rose. And so we found essentially no results on pregnancy outcomes that we had seen in the earlier trials. But we see that the trial conducted in South Carolina was conducted with families where 43% of the mothers were either college graduates or in college at registration. Far, far fewer needs than we had seen in the other trials. Well, it just reminds us how critical it is to serve those where the needs are greatest. And so with this, I'd like to turn this over to Deirdre. Deirdre, you ready?
Hello, hi everybody. My first thing is to apologize. My camera's not working for the first time ever. So apologies that you're not seeing me, but you're all very welcome. As David has taken us to this point, as well as the development of research and evidence-based practice, we also encourage practice-based evidence through quality improvement, innovation, and adaptation of the programme. It is a challenge, striking the balance between ensuring the programme is delivered as intended and in lines with fidelity of the programme, and allowing some flexibility towards the culture and context of the implementing country. The programme has a number of core elements for implementation, and countries that are looking for some flexibility will work with the global team, and we will discuss the challenges through implementation, and we will support them through getting a consensus on what needs to happen. It is expected that all innovations, adaptations, augmentations are evaluated for impact as a test before being adapted as a part of the country's programme. All right, David, you did my slides. Could you move on to the next one? This is some examples of some of the programme innovations and adaptations. We've looked, we have a programme augmentation of intimate partner violence. We have also developed a caregiver child interaction tool for countries that didn't have any sort of attachment or parenting interaction tool in place. And we've also looked at the best contexts and conditions for family nurse partnership to be delivered, and also looking at improvements to maternal depression and anxiety. At the minute, the formative development and testing of some adjustments to the programme where a woman with previous live birth is so the programme is now being offered to multips in some countries, and also we're also allowed for an adaptation of where it could be parents could be enrolled later in pregnancy and postpartum. Again, all our implementing countries strive to the highest possible quality of the programme implementation. And this is at site level, at team level, at national level and global level. Each country has a framework in place of their own quality improvement programme that uses data in a positive way for growth and improvement. And these are some of the examples of our global quality improvement programme for this year going forward. So this year, with my appointment to my new role, we had a change to the global structure. It is still David Olds and the University of Colorado are still the license owners, but we developed a global collaborative guidance group of all the strategic leads in each of the global countries. And the USA is also included in that. And from that, we have a number of subgroups which look at different areas of the programme: education, clinical, data, and Sue will be soon leading the Global Research and Evaluation Group. And this seminar series is part of that work kicking off. We know that collaboration is the central skill for improvement for our growth, adaptation, and sustainability of the programme in the long term. The background was to look at a sustainable model for taking the programme forward, to engage our global partners who are quite experts in terms of implementation now in the decision making, and also to reflect and promote the self-efficacy within and among with the countries that are involved. So we are all working together to promote learning and growth of the programme. Next slide. So the aim of the Global Collaborative Guidance Group was to create a more robust structure and arrangements to support the global work that we were doing, both for new and existing countries, and to, I suppose, take a more collaborative approach in the decision making and for all the countries involved. And this reflects our nurse family partnership values, which are collaborative, transparent, accountable, client-centred, culture of learning, and future-focused. The benefits we hope for the countries involved is that we will be sharing our expertise with policy implementation and the research communities of all the countries, that we will be able to ability for all the countries to be involved in shaping future direction and learning and supporting from each other. And we have early evidence that that actually is working very well. We also promoting the quality assurance measures that we have in place to protect the reputation of the programme. We also have invited our new countries that have been involved, and it gives them the opportunity of working with more experienced countries and provides a clear pathway to progress through the different stages of implementation. It also continues to strengthen our links between each country. So what made us move to this way of working, and we felt that the time was right. Nurse Family Partnership, we are totally committed to improving all systems and processes. And we realised that our dynamic system was, but that we actually, all our partners were much engaged, that they solve problems together well, that they resolve conflicts and create a lot of extra value working together. And we knew that within that there was a shared motivation. We could see the shared leadership, the knowledge and the growth and innovation that was happening at a country level, and the sharing, the willingness to share with each other and to work with each other. And also we felt that with all the experience and expertise there was in the strategic leadership in the countries, that actually this would generate the right conditions for collaborative leadership and decision making and creating better outcomes and improving the programme together. But like in all things FMP, our Nurse Family Partnership, we will evaluate the process. After 12 months, we will have a look, and how will we know that it's working well? Well, it's a Nurse Family Partnership is always in a dynamic state of improvement. So we will use a mixed methods evaluation after the first 12 months. And of course, this will always lead to adaptations and innovations of our global collaborative system. And we look forward to seeing the improvements. Thank you. Any questions? David and I's email addresses are there for you if there's any questions after tonight's question and answers that we don't get to, Sue. Thank you.
Great. Excellent. David and Deirdre, thank you so much. I mean, it's just really quite exceptional to hear this overview today, starting with, just that first study in Elmira, New York, and seeing where we are today with truly a global community of multiple leaders in different countries working together to think through how to rigorously and carefully not only evaluate the program, but how to implement it and deliver it in a way that honors the core model elements of the program and that specifically meets the needs of families. So now I wanted to open it up for questions. So if anyone has questions for David or Deirdre, please either put up your hand, or if you pop a question into the chat, I will see it there and can moderate from that. As I wait, I have already received a few questions, so maybe I'll start with those few questions that I've received, and as we wait to see what other questions are going to pop into the chat. So the first question I have, David and Deirdre, is how does a new country or a new jurisdiction around the world get chosen to join NFP or become a pilot site and begin the work to adapt it for their context?
Something Deirdre, do you want to take it? I can
No,
take it also.
you could
Well,
take it, David. Yeah.
I think we can do this one together, Deirdre. We're a team. We've been invited to develop the program in some contexts around the world early on in our replication process, where we chose not to do that replication because it was because the governments were unstable, the political situation was unstable, and that the resources to do this work in those contexts seemed limited. I would say that, and we felt early in the process that we needed to see whether it could even work well in high and middle income countries. So we held off on that. And I think that it's safe to say that we believe that there is evidence that the program is working in contexts outside of the United States. And so that for that reason, we want to, we're more open to entertaining applications from other countries, both in high income countries, but also to consider other middle and low income countries today, because I think we have more experience under our belt. But I don't know. Deirdre, what do you think?
Yes, David, I think at the minute we're probably able to welcome any country that is interested in having a discussion with us. There is probably, as somebody has suggested, an impact assessment that has to be made.
Yes.
You have to have the right conditions in alignment to, I suppose, get the best from the program. But I think rather than outline those now, if anybody is interested, please do contact either myself or Gail Radford Trotter, who's the international consultant, and we can discuss it further. There is a document, there's a lot of documents and materials that you could read after that discussion, but I think there are different factors that need to be in place before a country is ready to be, I suppose, considered. But we're very welcome to have those discussions with people.
Great. Thank you, David. Thank you, Deirdre. And in the chat, I've also put a link to the NFP International website, to the page where there's additional information around implementation. And Deirdre, you already started to touch on a bit of a question that was asked by Anne McDonald in the chat about if there is a process to undertake an impact assessment before implementing into a country. And even one where there's already a public health home visiting program in place. And so you've already identified that, yes, there is an assessment, and that in that discussion, a whole bunch of criteria will be discussed, including, the conditions of the country, local or national or federal government policies, an understanding of the commitment and the time and the resources to implement, nursing workforce and funding. So certainly a very fulsome conversation. So thank you for asking that question. Okay. And I see another question here about, quickly introducing the potential for this in mainland China as part of a postpartum home visiting service, and an opportunity to discuss, opportunities to adopt NFP practice in different regions of Asia. So again, I would encourage you to look at that link and follow up. There's information on how to contact the NFP International Program, to connect with Deirdre, and to start to set up a meeting for those conversations around if this is feasible. So another question that has come in, David, you briefly mentioned in your presentation that there is research being conducted to evaluate the effectiveness of NFP in serving families who are multip families, or who are not mothers preparing to parent for the first time. I'm wondering if you could just speak about the outcomes from that study. What are the options for other countries who are not yet serving multip families? Will there be any changes to the core model elements? So if you could just speak to the multip world a bit.
Sure. Let me just say that we've in some ways undertaken this work with multips because we had requests from various communities and countries to serve multips. We agreed early on to serve multips in Australia because a lot of the feedback that we got was that serving Aboriginal and Torres Strait Islander families, only serving first-time pregnant women would be out of touch culturally. So we granted a variance and said, if you're doing this in often remote communities, small communities in Australia, go for it. And you can serve multips. The focus has been primarily on women having their first pregnancies, but they are allowed to serve families, often families in need, where the mother has had a previous live birth. Well, one of the things we want to make sure in doing all of this is that the program doesn't lose its focus in serving primiparous families, because we don't have the same evidence base. There has been some qualitative work and quantitative work indicating that women with previous live births, some at least, really would love to be involved in this program because they want to get it right this time. And there is some quantitative work that's in process right now that we'll share with you. We've told sites that have requested the variance to serve multips that we will allow it, but they need to just recognize that the evidentiary foundations for serving that segment of the population is limited. But we will grant these variances. And so it's a piece of work that is in transition right now, and but we're quite obsessive about this, so we want to make sure that we're making good use of scarce public resources.
I think the only thing I would add to what David had said too is that we know that it works for families with multiple disadvantage and very overlapping needs. And, that's really the most important part of it. We know that the research tells us that it works well for first-time families, but I think we need the conditions to make sure that subsequent, families who maybe are multip families, that they actually have those overlapping needs, but also have the ability to change as well. Thank you.
Thank you. So another question, this one is related to nurse-family partnership and intimate partner violence. The comment is, that improving nurses' resources in addressing intimate partner violence has been tested as an innovation in multiple or in NFP trials in the United States and one in the Netherlands. And David, can you speak to, trial effectiveness or any overarching thoughts around NFP with respect to addressing the maternal outcome of intimate partner violence? And
Well,
then maybe Deirdre, are there steps to translate the learning into practice?
Well, so let me just say this: you are the PI, you are the you are the lead on this work on intimate partner violence. So you've conducted a cluster-based randomized clinical trial of the program. You developed the clinical foundations of this work. So why don't you take that question?
Thanks, David. And to anyone who knows me out there, certainly this was an incredible team effort. And the PIs that led the trial were absolutely trialists with quantitative research experience. My colleagues, David and Harriet McMillan and Jeff Coben and Michael Boyle. We developed an intimate partner violence intervention in the US and spent 2 years developing an intervention that was deeply informed by the experiences of nurses, supervisors, as well as, again, a deep exploration of the needs of clients and what they perceived would best meet their concerns or challenges around parenting within the context of having abuse and violence in the relationships. When we did evaluate this IPV intervention in a cluster-based RCT in 15 sites in the US, we were disappointed to see that we had that it did not demonstrate significant outcomes in the intervention group. What we saw is that in the group that was delivering nurse-family partnership and augmented by the IPV intervention compared to sites that were continuing to deliver NFP, but that didn't have access to the education and the clinical pathway. We saw that there were reductions in intimate partner violence rates in both groups. So that, in one way that demonstrates, the strength of NFP as a whole. So learning from our experiences in the US, we did embed also a qualitative process evaluation, and we learned a lot about implementation of new innovations within NFP and really what supports are required to successfully support supervisors and teams to implement and embed complex innovations within their existing practice. And the exciting thing is that we learned a lot from the US, and we took those lessons and revised and adapted curriculum and programs in Canada, in Northern Ireland, in Norway, and we continue to evaluate. So one thing I'll say is stay tuned for some results coming from Canada, as we begin to report on maternal outcomes from the trial in Canada. So we are translating the learning into practice and continuing to adapt the innovation and find ways to better support individuals to implement new innovations into practice. So thank you for that question, and thanks, David, for the throwback here. Okay, I'm just quickly looking for other questions. Okay. A question. Thank you for such an insightful presentation. My question is whether it is feasible to implement nurse-family partnership in Ghana, in Africa.
Let me just say this. I think I saw that question from Abraham. And let me just say that we are deeply digging into this and thinking about Ghana because the context there are both needs, but there seems to be political stability and other types of infrastructures that would be needed to support the program in Ghana. So we're hoping to work with you folks in Ghana to really explore this possibility and doing it really thoroughly. So please stay tuned. We're on it, so to speak.
And I said, you know, Ibrahim and Marie Young had also asked a similar question. And David, thank you for that response, because I think it does require a really deep conversation and thoughtfulness. And David, today you have spoken so much about hiring the right nurses to do this program. And you know, in full transparency, I'm a nurse, and I think what nurses also bring to this program that might be different from other home visiting programs that use paraprofessionals or community health workers is that nurses come with a very distinct and specialized set of knowledge and skills, and come with orientations to be able to address health issues and social issues for families. And so while nurses come with the ability to establish therapeutic relationships, they also come with very specialized knowledge that makes a difference. So as we look to other countries, the important thing, even from an equity standpoint, is to understand if that workforce is even available. So many countries around the world, there's nursing shortages. You know, so a clear assessment of the capacity and availability of the nursing workforce. So great question. Oh, and I
Sue,
see,
can I,
yes,
yeah,
oh, yep.
so can I just follow up on that? I want to say, first of all, I agree completely with you. You saw the results of the Denver trial. Families opened their doors more frequently for nurses than they did for people with other backgrounds. And I think, and so in the US at least, nurses are the most trusted professionals in all of US society. And yet in our global replication in Australia, we're finding that there are limited numbers of nurses in some remote rural communities, and we are entertaining the possibility of having trained paraprofessional workers who get additional healthcare education to fulfill this role in reaching vulnerable families in really remote areas. We need to evaluate the extent to which that really works, but it gives you an example of the kind of work we are doing to think carefully about serving families in rural, under-resourced communities. I'm sorry. Yes.
No, great. Thanks, David. And I see that Marie Allen, you have your hand up. So would you please ask your question?
Yeah, it actually just plays right into what you were saying, Susan. It's kind of, first, I'm an NFP nurse, now a home visitor, so I'm really humbled by all that you're saying about what it takes to be an NFP nurse. But I guess that made me wonder, are there any programs to help maybe instead of find those NFP nurses, create new ones in the countries that are being established, and you just knowing that they're probably going to be the greatest experts, kind of helping imbue them with the qualities it takes to be NFP nurses?
Well, Maria, I can't say that the closest that we have. Are you asking about getting existing nurses trained to become NFP nurses?
Yes, exactly. Yeah.
Okay.
Yeah.
Well, one of the things that strikes me, Marie, is that people who go into nursing in general are really built to serve. That's their motivation in life about the work they do. And, you know, it just moves me so much. And so I suspect that in every country where nurses are present, that there is this drive to serve. And for many individuals, I've had nurses say to me, I've been in nursing for 25 years. What I learned when I became involved in this program, I felt like I found my home. This is what I was meant to do. And so I think that making this program available in a country can lead nurses who are driven to this kind of work to choose this program. And I think that part of it has to do that we as human beings are moved by protecting our protecting our offspring, protecting our children, and protecting those who are vulnerable. That kind of motivation is fundamental. I might say that it's what's added to this is the science, and that says that it's not just a good idea or something you feel is right, but the evidence says that this really will make a difference. And so in the US, I can say with some kind of amazement, the nurse family partnership strong bipartisan support in our deeply divided country for decades. And so that's why, and it gets federal funding. So I think it's the heart, and I think it's the mind. And you heard me say that in rural Australia, we're entertaining the possibility of training additional people to serve in this capacity.
Great. Super. Marie, did you have a second question there? I just saw a quizzical look.
Yeah,
Or a
that's a
follow-up.
good, well, that just kind of makes me ponder a little bit, I guess. So what, let me see if I can put it into words. So, and well, let me think on it. Let me think about it, and I'll raise my hand again.
Okay, great. Thanks, Marie. Okay, question both for David and Deirdre. How did the pandemic fundamentally change the NFP program around the globe?
Deirdre, do you want to talk about this, or would you like
I
me
will.
to? Yeah.
Well, no, I'm quite happy to. I mean, as you know, family nurse partnership works best, our nurse family partnership, when it's home visitation. Working with the family in their own home, we know demonstrates the best outcomes. People are more relaxed. You can assess the home environment, and it just is most definitely a home visiting program. And then came along the pandemic, and we had to very quickly adapt and adjust to the situation where we had very vulnerable families at home and only with very little contact with any other services. So most of the family nurse partnership or nurse family partnership teams globally quickly introduced face time and different online home visiting program so that they could continue to visit family, to continue on with the program and throw that lifeline to families. So they did it on an online basis. And we, the global team at that stage did, I suppose at different points, did a quality improvement and shared the learning between countries of the different initiatives that were being used and how to help and support online working. And we learned a lot from it. But I think fundamentally it was very, I think we all felt a sense of relief to go back to visiting back in the homes where you really could see the environment that people were living on. Just made it so much difficult for the sensitive issues around intimate partner violence, and those issues probably weren't as easily I suppose worked with actually not having that sense of who was around in the family environment. But yes, we've learned a lot. It has its place, but actually it is a home visiting program, and even to remote areas, it does offer some value, but it doesn't offer or replace the home visiting service.
Yeah, there's something so powerful about that face-to-face encounter, regardless of where it occurs in a home or in another community setting.
If I can just follow up on this as well, my youngest son used to tell me that I was the master of the obvious. And so among the things that you can't do using this kind of platform or telephone is get a good sense of how mothers and fathers are interacting with their babies and toddlers. So you need to be face to face to get that piece of it as well. So for all of those reasons, we think that doing this work in the home is really far superior. but there are those situations where having these telehealth mechanisms can fill in. And I think we're getting it right.
I mean, I was so impressed by the innovation of family nurses at that time. They were having picnics, they were having yard visits, they were having garden visits. They tried so hard to maintain all the infection control guidelines and tried to visit their clients. They were probably the most tenacious group of nurses in terms of trying to get out to their clients that I have ever experienced.
Yeah, innovation and flexibility. I think those are also core attributes of many public health nurses or nurse home visitors. Now, here's another question from very close to where I am, from Caroline Edwards here in Ontario. Is there any evidence regarding the frequency of visiting clients for successful outcomes, weekly, bi-weekly, or based on client need?
Yeah, I can at least hem and haw around that question. Let me just say this, that the program is designed with weekly visits for the first 4 weeks after registration in the program. And we've done that. We differ from the way obstetrics work, in the sense that we feel that getting to families as early in pregnancy frequently is critical. And that means that they're in a position to address the kinds of things that I was mentioning, substance use and stress and so forth, identification of emerging obstetric complications, all of that. So and then the visit schedule drops off to every other week. And then postnatally, for the first 6 weeks postnatally, it's once a week. And then a schedule of diminishing frequency until the child reaches age 2. I can say that in general, that when nurses are not connecting with these most vulnerable families, they either disengage and drop out, or that the impact of the program is diminished. But to quantify that in terms of numbers and the timing and the amount has not just been articulated the way I think you would like us to. So thanks for posing that question. We just don't have the detailed answer that we would like.
Yeah,
Just to add, we also have the STAR framework, which is a detailed assessment of need, which allows us to maybe dial down the number of visits for families that are doing really, really well, and prioritize and personalize the program to their needs. And then it also allows us to dial up the number of visits that maybe a family might need, that they are particularly going through a rough patch or a difficult time. So there is a little bit of flexibility within the program schedule based on the personalised needs of the family. And the STAR framework helps us to manage that. But it also, and some countries have used it very well to graduate families a little bit earlier in the program if they're doing extremely well.
Great. Thanks, Deirdre. Now, Marie, I said back to you if you had that second part of your question. So we'll pop back to you and then we'll take time for maybe 1 or 2 more questions.
I do. Thanks for coming back to me. So I guess my question really is focused on the research of nurses and kind of any science that's been done in incorporating the culture of the nurses of the countries that they're in, and then just kind of what evidence we're gathering on how, like you said, Susan, how to get these nurses that are interested and how to keep them and things like that.
I think that's a wonderful question. And I think that among our team, I think the person who has the greatest insight is Professor Jack. So, I mean, I have some thoughts, but I'm interested in what Professor Jack has to say about this, because she specializes in this kind of research.
Thanks, David. And I was just pulling up our link. In Canada, as we have done the randomized controlled trial, we also conducted a 5-year adjunctive study, a process of evaluation, to really carefully understand how NFP was adapted, implemented, and delivered in 5 different health authorities or health regions in the province of British Columbia. And a specific focus of our work was to look at questions like that. What are the elements of the program that support the retention and the attrition enrollment of nurses in this program? Why do nurses, both choose to work in this program, and why do they value staying in the program? And I've put the link there, but just quickly, some of the things is that this program, because of the required core model elements, and I'm really speaking to the nurses here as well as the program administrators, this is a program that provides nurses to work at their full scope of practice. Many programs have been reduced to what I personally call checklist nursing. You go in with the requirements of an organization, you ask a bunch of questions, checklists, you identify client's need, and you refer on. And that may be very appropriate for families who are well-resourced. But in NFP, this program, nurses are doing fulsome, comprehensive assessments. They are working carefully with families to identify what are their needs, and then developing plans of care that are tailored to the client needs. And the nurses in NFP have the education and additional education and training through NFP to actually nurse or to intervene, to address mental health symptoms, to do safety planning with families where there is intimate partner violence, to identify goals and engage in behavior change around reducing use of different substances. So we know that that was one of the biggest findings, is that they can work at their scope of practice. And again, that speaks to why nurses in the program. There is a scope of practice there with very specialized skills and knowledge. And it's also about professional fulfillment. It is about finding the right nurses to work in the program, those who are flexible, who can go with the flow, who are able to adapt to families' needs, and have that sense of fulfillment, and rejoice in seeing families really overcome some very difficult circumstances. The other reasons that I think nurses but that our evidence showed is that this program has structure. It provides nurses with resources on what to do and how to do it. And it's supported with really comprehensive education, as well as they value the opportunity to have high quality reflective supervision. So I've put the link there in the chat, but those were off the top of my head, a few things that I hope answer your question.
Perfect, thank you.
And yeah, you're very welcome.
Can I just add, I want to say one thing, Sue. One of the things that you said, and I think is really critical, is that having the right supervisor who really is doing everything she can to promote both reflective supervision, but to make sure that nurses are protected within their organization, supported by their community, their reputation is supported, they are valued in the organization and in their community. All of that, I think, I'm just building on what you were saying. It's really critical, I think.
Absolutely. And we've got time for one more question. And this is a question from the United States in upstate New York. So it's appropriate that, David, you started the whole chat today talking about upstate New York and Elmira. So I think it's appropriate we end with a question in that same location. What data do you have for program impact with individuals where English is not their language of origin, or for individuals who are refugees or newcomers to the US? And the rest of the question is, so what do we know about program effectiveness for those clients? And how can we support nurses who are supporting clients where there are language barriers, and that there's limited resources for interpreters or hiring nurses who speak these multiple languages?
Well, I think I was hoping this would be a question that would be one we could hit out of the ballpark, but this is this is a tough one because these are challenges not only in the United States, but it's one of the reasons Norway came to us and wanted to deliver the program in Norway. And so they have these pockets of families with high needs, and they want to make sure that they're being served well. And of course, having translators is a way to go, but we don't really have the kind of evidence that I would like to see to determine whether this is a good use of scarce public resources. I think it's, my guess is that it will be helpful, but there is just something involved in the translation, the interpretation process that creates a separation between the nurse and the mother and the family that makes me worried that it's going to be a challenge. So what you just did is outlined a question that we need to dig into, right, Sue?
Absolutely. As soon as you said it's a tough question, I thought that's why researchers work with clinicians, because it's really nurses and nurse supervisors who raise the questions about what are the challenges in practice. And as researchers, we come with one set of tools where we can start to understand what are those challenges. So thank you for asking the question. And you're right, it's something to put on our radar. Both how to work effectively with interpreters, but also to look at the impact of the program for those families where English is not their language of origin. So thank you. So with that, I mean, it's hard to believe how quickly 90 minutes goes. And I would just really like to thank both David and Deirdre for sharing their vast wisdom with all of us today and joining us. And thank you to all of you who have joined us from across the globe today. I know we've had people from many different countries. And for those of you who are still here, it is our goal every quarter of the year to now have a webinar series really highlighting advancements in NFP research and evaluation from different countries. And so with that, our next webinar will be September 23rd in North America, Europe, which will be the morning, I think, or late evening, maybe on the 24th for Australia. But really excited that Dr. Andrea Gonzalez will be our presenter and speaking about building healthy foundations, the impact of NFP on maternal and child biomarkers. And so any of you that have attended today, there will be information sent to you about the specific time and how to register. So thank you, David. Thank you, Deirdre. And thank you to everyone for joining us. And I hope we'll see you again in September. So thank you and have a lovely rest of the day, whatever time we find you at. And goodbye. Thank you.
Thank you.